Good afternoon and welcome to AAAS. I'm Charles Dunlap, the Interim Director for the Center of Science, Policy, and Society Programs. Our lecture this afternoon on the opioid epidemic is the second in the 2017 AAAS Dana Foundation lecture series on neuroscience and society. Our first lecture this year on the brain and video games was held in March, and our third lecture in September will be on meditation, so please keep an eye out for the announcement date. The Dana Foundation is a private philanthropic organization that supports brain research through grants, publications, and educational programs like this one. For the last 5 years, AAAS has partnered with the Dana Foundation to present an annual lecture series on neuroscience and society. And by my count, this is the 20th lecture in the series. We're grateful for the Dana Foundation's support of this series and for Deborah Runkle's leadership of the series in our Scientific Responsibility, Human Rights, and Law program. And with that, Deborah.
Thank you, Charlie, and welcome. It seems to me as though hardly a day goes by, but there isn't some story that I see either in the newspaper or on the evening news about the opioid crisis. And as I was thinking about that today and leafing through the paper, sure enough, on the front page of the Metro section of the Washington Post is a story about how the governors of Maryland and Virginia, along with Washington, D.C.'s mayor, are getting together to form a combined database to keep an eye on prescriptions and who is getting these drugs. So it's just another day. And then a few days ago, somebody sent me something that said that in a small town in Kermit, West Virginia, where 392 people live, a pharmacy there received 92 million pills of opioid painkillers. 92 million seems a lot, doesn't it, for a town of 392 people. So there's really a very bad problem going on, and we are going to address it tonight, looking at it from several different points of view. And by the way, when we're all done, I want you to know that we do have a reception planned, so for the end of this. So tonight we're going to look at an eagle's eye view of the opioid epidemic, a more close-in view from the National Institute of Drug Abuse, and then a talk from Karen Drexler of the VA about possible treatments. But our first speaker is Dan Ciccarone, who is a professor of medicine at the University of California, San Francisco. He specializes in community medicine and treating diseases and poverty. He was a leader in the HIV/AIDS epidemic in the early days. And so he's going to talk to us tonight, as I said, an eagle-eye view of the scope of the problem. Dan?
Thank you, Deborah.
Oh,
There we go.
your microphone.
So I'm a typical academic, and I can't even begin to talk until my slides are up, you know. I'm a little lost without them. So hi, everyone. Dan Ciccarone, UCSF. Yes, I'm a family community doc, so my perspective is one of trying to see ways towards increasing community health. I started with the HIV epidemic, but found my way to drugs about 17 years ago. The drug epidemic, that is. And I'm here tonight to present intertwined opioid epidemics, prescription pills, heroin, and fentanyl. Did the wrong thing again. Let's try again. Voila. So I'm going to go through some epidemiological data on the opioid overdose epidemics, comparing prescription pills with heroin, looking at some demographics and some epidemic curves. I'll spend a little bit of time talking about the illicitly manufactured fentanyls, one slide on etiology and one slide on other consequences. Yes, I got it. Most of what I'm presenting is publicly available data, CDC and the DEA. For example, a little bit's going to come from my study, Heroin in Transition study funded by the National Institute of Health, the National Institute of Drug Abuse. For the first time since 1993, the US death rate has gone up year to year. 1993 was the height of the HIV/AIDS epidemic. And here we have the 10 leading causes of death as of 2015. Heart disease and cancer, the two big elephants in the room, sort of cancel each other out. One went up, one went down. But if we go to number 4, unintentional injuries, we see a clear bump up 2014 to 2015. Now, we were shocked in 2011 to find out that 2 of the leading causes of unintentional injury death had crossed over, with drug poisonings on the rise and motor vehicle accidents on the decline. Of course, this is good news in terms of motor vehicle accidents, but bad news in terms of the drug epidemic. This is a graphic from the New York Times. I was working with Josh Katz on this. Drug overdoses, drug poisoning overdoses, the number of deaths have now exceeded car accidents, gun violence, and even HIV. You can barely see the HIV line there. I apologize, but it's a steep rise up. This is peaking around 1993, and then a decline. We've moved from epidemic, a drug poisoning or opioid epidemic, to a crisis. Looking at hospitalization data, this is the curve for the opioid overdose epidemic. Dramatic rise up, 1993 to about 2011, and some good news. A plateauing, perhaps even a decline post-2011. This, of course, is based on the good work we're doing to restrict excessive prescribing practices. Unfortunately, this is now heroin overdose hospital admissions, dramatic increase up since 2008. It's not necessarily the magnitude in this slide, but that steep curve that has me concerned. Year over year, no end in sight. What's fueling heroin-related overdose? 3 possibilities. One is there's evidence that the number of heroin users, the denominator, is rising. And they're coming from 2 paths. One group is coming from opioid pill dependency and finding heroin is more available and cheaper and is replacing their high level of pill dependency with a heroin dependency. Other folks are coming to heroin straight away now. Heroin is cheap, it's pure, it's good, and it is everywhere. The supply has changed dramatically in the last few years, and the availability has gone up. Places like Burlington, Vermont are not supposed to have good heroin, and they do. In terms of the transitioning, my group has written stories, has written papers on this, one called The Intertwined Epidemics. We used that term as early as 2012, that one group of opioid users could transition back and forth, and that's because the opioids are treated equally in the body. We also wrote a story about Every Never I Ever Said Came True, stories of folks who are on heroin and how they transitioned, with all the new users and the young users telling the stories about how they started with pills and then moved over to heroin. This is a picture I took in an alleyway in Philadelphia just to sort of symbolize the pill to heroin intertwining. And here's some data from my group looking at comparing the demographics by age for these 2 epidemics. Here's the pill overdose problem. It's now predominantly, this is 2012 to 14 data, predominantly in an older age group, 50 to 64-year-olds, whereas heroin, a younger age group. It's been written that if you want to show evidence for a drug epidemic, show a rising problem among young people. Well, there we have it. But if we shift this over, we see some evidence of the intertwined or the transitioning between opiate pills and heroin. As the opiate overdose year-to-year rate goes down, you can see from the blue to the green, we see that heroin overdose is going up in that same age bracket, 2012 to 2014. By geographic region, we see even a starker difference. Opioid overdoses relatively even across the country over a long time period here. We like to think that it's worse in places like Appalachia, and perhaps it is a little bit, because there are actually statistically significant differences in these curves, but to our eye, they look more or less even by region. And this is not true for heroin. Heroin is dramatically different. The Northeast has had a problem for multiple generations with an endemic issue with heroin, but the Midwest, that second line, the red line, which is now highlighted with the gold arrow, going from low levels of heroin overdose to very high levels of heroin overdose. Clear geographic disparity that cannot be explained by a simple opioid pill to heroin transition among the population at risk. So in addition to that story, we have to tell another story, that heroin is itself becoming a more dangerous drug. It is being adulterated or contaminated with synthetics such as fentanyl, and it's coming in a new form, which has received very little press. Let's talk about fentanyl. Fentanyl is integrated into the heroin supply. It is not, you don't go to a separate corner down the street and ask for some funny street name for this new drug called fentanyl, right? You go and buy heroin, and the heroin you get, if you're in that right region, the right mill town in Massachusetts, for example, you're going to get fentanyl-contaminated heroin. It is a potent synthetic opioid, 100 times as powerful as morphine by weight, 30 to 40 times stronger than heroin by my calculation. Its appearance, we've had multiple waves of it in the past, but its latest appearance has been a long one, much longer than the other waves, began in the late 2013. It's illicitly manufactured fentanyl, not pharmaceutically diverted, according to the DEA. And it's analogous to what we see in the cocaine supply with levamisole. Levamisole is an adulterant. It's a booster of cocaine. At once it was considered sort of a side event, a rare event. It is now ubiquitous in the cocaine supply. And this implies that there may be a future for the heroin plus fentanyl as the new heroin moving forward. In addition to the main chemical, which is fentanyl, there's at least 24 analogs. And there's other novel synthetics like U-47-700. The big bad boy we're worried about, carfentanil. Actually, there's a couple now, but this was yesterday's news. Carfentanil is the big one, 1,000x morphine, 300 to 400 times as strong as heroin. This is simply not meant for human consumption. It's a large animal pain reliever. So if your elephant has a problem, that's what you need. The DEA would like to tell us that, I have no privileged information, but the DEA in its reports will tell us that the illicitly manufactured fentanyls are coming from China through multiple routes of North America. The predominant route for the heroin, not the contaminated pills, but for the heroin, is through Mexico and coming up through cartel distribution. And where's it going? These bottom 7 states are places that have both high fentanyl supply, as according to the National Forensics Lab, drug seizure data, and high rates of synthetic opioid deaths. Midwest, down to Appalachia, up to New England. Same states that have the excess heroin overdose deaths. So I'm going to present one slide on one reason why we got here. It's called supply side theory. When morphine and heroin was synthesized and promoted as pharmaceuticals, they were quickly adopted because they worked. They did what people wanted them to do, but they also became problem drugs. So we have novel drugs, technological advancement in terms of the synthesis, and technological advancement in terms of the invention of the hypodermic needle, and iatrogenic causes to the first wave of the first opioid epidemic in the United States. We've had waves of heroin use, misuse, and abuse over the generations, some of which have been cultural, some of which have been related to new sources. So the Vietnam era heroin epidemic, devastating U.S. inner cities. That was a new source of heroin, type 4 heroin coming from Southeast Asia. The Colombian heroin wave, which people don't often know about, came when the Colombian drug cartels brought in an entirely new product. They were well known for cocaine, but they brought in heroin in 1992, led to a wave of problematic drug use in the United States. Now we have the opioid pill problem, again, iatrogenic with a novel form. Think about the ERLAs, the extended release long-acting capsules, which has high doses of powerful opiates in them. but that were easily abusable, crushable, dissolvable, and injectable. Heroin's coming in now, in the late 2000s, new source form. I haven't spent a lot of time talking about it. I'd be happy to answer questions about it. But Mexico is producing a highly potent powdered heroin now that's never been seen before, and we don't know much about it. Synthetics are also coming in. This wave of fentanyl beginning around 2013, a new source and a technological advancement in that it's highly potent and acts as a booster for heroin. I'll remind everyone that there's other consequences besides overdose in this opioid crisis. Injecting drugs leads to an infectious disease risk, bloodborne viruses, hepatitis C, and HIV. We should be mindful that of the severe HIV outbreak in Scott County, Indiana. There are many Scott County-like counties in the United States. We also have to be concerned about bacterial infections, endocarditis, skin and soft tissue infections. They cause a lot of suffering. They cost us a lot of money in terms of treatment. All of these things are preventable. Part of what my research is to talk with users. You know, these numbers hide the pain, the lived experience, the resilience, the coping that's going on among the using population. We do ethnographic work. We meet with users in the street. We watch them as they prepare their drugs and inject. All the while, fascinated by the new chemicals that are out there. They come in new forms, new colors of powders, new forms of powders, and new solutions. This bright yellow solution, when I first saw it, it freaked me out. Never seen it before. I've been studying heroin for 17 years. Right? This is quite like the synthetic. I actually don't know which one. But if it's freaking me out as a public health researcher, you can imagine what the users are going through, right, in terms of trying to adapt to this new thing that's out there. They want our help, and it's up to us to provide it. So in summary, is this one epidemic or three? I'm proposing that we start to separate them. We don't consider this one intertwined opioid epidemic, that we need to treat heroin and fentanyl differently than we're treating prescription pill problem. That supply shocks can lead to epidemics. Unfortunately, that does not mean that we're going to put the genie back in the bottle and that supply control is the answer or the only answer. Yes, this is a crisis of an epidemic of crisis proportions as we are besting the HIV epidemic at its worst, unfortunately. But it's also a crisis of epic opportunity. We turn that HIV epidemic around. Right? Look at that dramatic drop down. This is the effect of appropriate government, cultural, social intervention, treatment and prevention. Treatment and prevention worked for the HIV epidemic. Treatment and prevention will work for the heroin and fentanyl epidemic as well. We should not treat these epidemics the same anymore. Controlling prescription pill practices, prescribing practices, we can do. Lots of effort out there. It's beginning to work. Okay? We need to treat heroin and fentanyl differently. We need better, more, faster. We need better surveillance. Hint, we need to treat this as a poisoning epidemic. We're treating it as a drug epidemic. We're counting the bodies, the dead bodies as they lie. We're not testing the drug adequately and informing the public adequately. And I'm happy to talk more about that in the question and answer period. We need more evidence-based treatment. Methadone and buprenorphine. Repeat, methadone and buprenorphine. Buprenorphine, buprenorphine, buprenorphine. We need more buprenorphine. CARA, the Comprehensive Addiction Recovery Act, is good. It's a wonderful bipartisan response. It is not going to be enough. There is no way it's going to be enough. We will need CARA 2, we will need CARA 3. And we need faster responses to overdose. Naloxone works. Naloxone needs to be not just in the hands of paramedics, and now it's in the police tool belt. Great, fantastic. We need to get it to peers, to the users, to their families. It needs to be this generation's EpiPen. Harm reduction saves lives. It's cost-effective and can bridge people into treatment. Repeat, it can bridge people into treatment. We tend to think of harm reduction as aiding and abetting drug users, you know, in the political, I'm in Washington, in the political sphere, right? Harm reduction saves lives, okay? And can be a bridge to clinical care and to treatment for the affected individuals. And that public safety and public health collaboration is sort of the new mantra. This can happen, okay? We need to work with the criminal justice side of things, the public health side of things. Stop treating the drugs as sort of the special privilege of the criminal justice folks and the injured bodies as only public health. Both sides need to work together. And with that, I'll end here with my acknowledgments. I particularly want to acknowledge Jay Unick, University of Maryland, who's the statistician on this project. And thank you all for your kind attention. A second.
Well, that was a good intro for our next talk, which will be coming from the government, and I'm anxious for you to hear how much the government is doing. Our speaker is Nora Volko, who is the director of the National Institute on Drug Abuse, NIDA, which is one of the National Institutes of Health. She has been a true pioneer in the study of the physiology, the pharmacology of drugs of abuse, and she will tell us a bit about what those drugs are and what her office is doing.
Yes. Good evening, everybody. It's a pleasure to be here. I think that I've been here several times. But and last time it was actually we were discussing the issue of marijuana and how all of the changes in policies was going to affect the consumption of marijuana and the potential negative effects. And today we're speaking about the worst crisis we've ever seen in the United States that relates to a drug. And what is interesting about this crisis, actually, which is very, very tragic, is number one, first of all, different from any other epidemic that we have had in the past, this one basically came out of the healthcare system. And it came out of very good intentions, which were we need to treat those patients that are suffering from pain. And this can be a serious, devastating disease, particularly if it's of the severe state. And it was recognized that actually there was a concern that patients were not being properly treated for their pain. So in the late 90s, at the beginning of 2000, it was decided that this would be the area of pain treatment. And among the many actions that took place was the Joint Accreditation Commission, which actually credits hospitals, demanded that you recognize pain as the fifth vital sign and that you treat it. And this was coupled with a very, very strong emphasis in the need to treat patients at the same time that there were limited therapeutic interventions that can be used for pain. And that, of course, resulted in a massive expansion in the prescription of opioids medications. And there was also while in the past there had been a lot of fear about the use of opioids for the treatment of pain because of the fear that patients will become addicted. That shifted dramatically at the beginning of the 2000s, and with very, very strong advertisement from the pharmaceutical industry to encourage physicians to prescribe opioids with a notion that we were taught in medical school, and was taught until very, very recently, that if you have pain, you're not going to become addicted to your pain medications. So we, as physicians, became very basically confounded about what we have learned in the past, that it could produce addiction, and now we were faced with we needed to treat and that these drugs were not being addicted. Unfortunately, the numbers, as physicians started to prescribe more and more opioids, it became clear that that was not the case. And as you look at the numbers backwards, it's always easier to look at things backwards. But I came to NIDA in 2003, and one of the first things that they were showing me were the results of Monitoring the Future. Monitoring the Future is a survey that we do in teenagers. And what struck my attention immediately in 2003 is that the rate of use of prescription opioid, Vicodin, was 10.5% among teenagers. And I had never, ever seen, and I'm a psychiatrist, in my life, a teenager taking an opioid. And that's what caught my attention. And then when we started to look at the numbers, we started to realize that there was a massive abuse of prescription opioids across all ages. But it was almost like people were not listening to us when we were saying, we have a problem with prescription opioids, because there was a sense that they were safe. And there was at the same time immediate counter reaction that you don't want to jeopardize the proper treatment of patients with pain. And it was not until we started to see numbers like this one that then the agencies realized, my God, we have a serious problem in our hands. And I don't think anything can speak better when you start to see numbers like these that grow so abruptly, rapidly. And these are the overdose death rates from the CDC. And you can see in 1999 that there were some pockets of the United States with very high overdose rates. In particular, you can see over there the Appalachian region. And over 14, 15 years, the whole United States appeared to become infected. You still see the main areas for overdoses in the Appalachian region. But as was spoken by the prior speaker, we also see areas in New Mexico that in the past had not seen it. And now I'm actually waiting for the data in 2015 because we're starting to see further expansion into the Northeast, that now it's driven by the emergence not just of pure heroin, but also of these fentanyl and fentanyl synthetic opioids. So why is it that opioid prescriptions could trigger such an avalanche of overdoses and deaths? And actually, this is the tip, because underneath it, of course, there are multiple adverse conditions associated with the use of prescription opioids. Well, opioid medications actually, there are a wide variety of them, but they have a common pharmacological effect. They basically are agonists at the mu-opioid receptors. And we have mu-opioid receptors all over our brain. Actually, we have them all over our body. And the opioid receptors are actually associated, and this is a brain image that actually shows, using positron emission tomography, in different types of colors, which is the color scale showing the highest levels, and the cold scale showing the lower levels, where they are located in our brains. And you can see that there is a very high concentration in all of the regions of the brain that are engaged in our ability to perceive pain, what we call the pain network. And that includes the anterior cingulate gyrus, or ACC, the thalamus, which is a central area in the brain that is filtering signals, and the periaqueductal gray, which is actually fundamental for our ability to perceive pain. There are also mu-opioid receptors in the amygdala, which is an area that allows us to have, is involved in emotional processing, and it is fundamental for the emotional negative reaction that we get with pain. And that area is also loaded with opioid medications. When opioid medications bind to these mu-opioid receptors, they actually inhibit the perception of pain, or they inhibit the emotional reaction when they are acting in the amygdala. And this is the reason why opioid medications probably are the most effective medications that you can have for addressing severe acute pain. And they act almost immediately. The issue was that acute severe pain is something that you may actually, one of these drugs may save your life. And I don't know if any one of you has been given them. I have been in a car accident, and I wanted to actually go unconscious. I wanted to faint because the pain was so intense. And then they gave me an opioid, and it was like magical. It was extraordinary sensation of well-being. Not just because the pain was gone, but also that great, great sense of euphoria and relaxation. And that's exactly why also these drugs are very problematic, because they are not just located in these pain centers, but they are actually located in that area over there that is called accumbens, nucleus accumbens. And this region is one of the most important regions in processing pleasure, pleasurable sensation. And when mu-opioid receptors bind into these regions, they activate that pleasure center. And that's why in those individuals that do not have an adverse reaction, opioid medications can be amongst the most rewarding and most addictive. And we also have these mu-opioid receptors located in the brainstem, which is the lower part of the brain in the back. And that's where we have many of the nuclei that are involved with physiological functions. And one of these nuclei is associated, it's responsible for our breathing. And it's loaded with mu-opioid receptors. And when opioid medications bind to this center, they actually inhibit breathing. And that's why you can actually ultimately die from an overdose, because you stop breathing. And this gives exactly the reason why opioid medications are far from being ideal as treatments, not in one instance for acute pain, but the problem emerges when you start to use them for the management of chronic pain. And chronic pain in general is considered when you have pain that lasts for more than 3 months. So what is the problem with opioid medications for chronic pain? They're very effective when you give it acutely. But when you give an opioid drug, your body rapidly becomes tolerant to it, which means that you need higher doses in order to achieve the same level of analgesia. And the higher the dose you get, the higher the likelihood that you become addicted. So the rewarding effects of the drug actually, when they are experienced repeatedly, leads to a conditioning response that leads you to crave that drug. And in those that are vulnerable, that can lead to the loss of control that characterizes addiction. And also, because the tolerance to the effects of opioids in the brain do not occur at the same rate in all of the brain regions. They are faster for pain and for reward, which means you need higher and higher doses than at the rate that they occur in the breathing center, which is, again, accounts for why these medications are far from ideal for the treatment of chronic pain, because you are going to need higher and higher doses, and the higher the dose, greater the risk of addiction, and the greater risk of overdosing from sleep apnea. As was pointed around, what generated this actually epidemic? The epidemic really started from our overprescription. And there's actually, in 2013, there were something like 235 million prescriptions in the United States. Sufficient amount to actually provide 1 month's supply of opioid medications for every adult in the United States. Now you say, well, maybe the United States, the adults of the United States are all suffering from severe pain. Well, if you look at the statistics, it is estimated that among elderly Americans, 30% of them suffer from chronic pain. But that in no way justifies this massive prescription. In fact, the United States actually prescribes between 80 and 85% of all opioid medications in the world. So this led to the recognition we're overprescribing. Overprescribing facilitated the diversion of these medications that then had a black market and started to be abused. And that then led to addiction. So you generated addiction to prescription opioids from 2 roads. People that were given these medications for pain with a belief of by the doctor that they will not become addicted because they had pain, become addicted, and then those that actually started to experiment with these drugs because of their rewarding effects. And these 2 actually ultimately generate a similar syndrome of addiction, characterized by that lack of control over drug taking and the escalation of drug intake. So there was a massive amount of effort that has been in trying to actually train physicians in proper prescription of opioid medications. Because when the Joint Accreditation Committee came in 2000, there was not associated with training on how to use these drugs. So physicians were starting to prescribe with no knowledge. So now we know, for example, that there are certain prescription practices for opioids that are particularly risky for overdose. When you give more than 80 morphine milligram equivalents, when you mix these medications with other medications that depress your breathing, like benzodiazepines, or when you mix them with alcohol. And yet, we're still continuing to do this type of prescriptions. Physicians are still prescribing these medications together with one another, thus increasing the risk of overdoses. But overall, we're seeing changes in the right direction. 15% decrease in the amount of opioids being prescribed between 2010 and 2015. This is not a major change, but it's still in the right direction. Unfortunately, this has not in any way changed the overdose rates that have continued to escalate, very much in line from what you've heard in the prior presentation. So here you have, last year, more than 33,000 people died from an opioid overdose. When you see the commonly prescribed opioids, you actually see they are stabilized, but they are not going down. But what is going up is that line of heroin and other synthetic opioids. The synthetic opioids are predominantly fentanyl and its analogs. Heroin is actually the result of, and this has been looked at in terms of what is driving this very high rate of overdoses. Well, for many, many years in the United States, we have very, very stable, low levels of abuse of heroin in this country. And the rate of deaths was basically, if you look at it, it's almost constant, 2,000 people dying every year from heroin. And then the amount of heroin you start to go up. It wasn't dramatic. It's not dramatic. It's actually around 700, 800,000 coming from 500,000. But the number of people has basically quadrupled, the ones dying. So what is driving this? We're driving it. We have a much purer heroin that is actually accounting for the very high rate of overdose, and it's a different population. We're seeing the young rural areas affected, young individuals in rural areas affected the most. So, and in the meantime, we're seeing that this heroin is being laced with fentanyl. And fentanyl, as you heard before, is extraordinarily potent, or with other synthetic. And that's what's driving the massive amount of overdose deaths. But of those new heroin abusers, 80% of them started abusing prescription opioids. And if you analyze really what happened and how the heroin was deployed coming from Mexico, now all of the heroin use in the United States is from Mexico, actually it started in states where they actually had the largest problems with prescription opioids. Those individuals that could actually became addicted to their prescription opioids, for them it was cheaper and easier to go to heroin. So 80% of the new cases of heroin are actually emerging from individuals that became addicted to prescription opioids. And this is important to address because what you don't want to communicate is that if we want to actually contain the heroin epidemic, we should make prescription opioids more available because what's leading people to change is that they are very hard to get it. That's actually exactly the incorrect answer. In order to address it, we have to prevent abuse and addiction to prescription opioids. Because if we prevent it, then those individuals are not going to transition to heroin. And these are actually the numbers that you saw in terms of how when a drug becomes, we know that for any drug that it is out there, that the price plays an important role. So we're getting heroin from Mexico that's actually coming with an extremely high purity, and it's decreasing dramatically the price. So the price of heroin in the United States has been going down. In the meantime, we're also seeing fentanyl is actually quite easy to synthesize. And the other issue about fentanyl, which is coming from China, as you heard, is that it's so potent, or some of these synthetic analogs, that you can actually bring it in very small volumes. From the supply perspective, this poses a tremendous amount of challenge because you are not carrying big volumes. You can carry these very small amounts of drug that can produce a multiplicity of doses. Of course, this poses tremendous challenges, not just from the supply perspective, but it actually poses tremendous challenges from the public health consequences associated with the overdose, the very, very high risk of overdosing with these drugs. So what is it that the NIH and NIDA is doing to address this problem of the epidemic? Our perspective is when we had the HIV epidemic, where we had the Ebola epidemic, we address it using science. Scientific solutions can provide those means to actually control this problem. And it's not different, in any different for the opioid crisis. So the way that we view it is we need to understand the root cause of the problem, that we had a problem with patients suffering from pain for which we don't have many alternatives. And in particular, the problem is for the management of chronic pain. And the Institute of Medicine estimated that in the United States, approximately 100 million people suffer from pain, moderate to severe. So that's one area. We need to develop better treatments and safer for the management of chronic pain. The other one is we do need to do interventions that can actually prevent the overdoses. We have naloxone, but we now need to actually go and design alternative strategies that can help those individuals that we are actually reverting from an overdose, because otherwise they're going to overdose again. And finally, we of course need more treatments for opioid use disorders. We have methadone, we have buprenorphine, and we have Vivitrol, but actually that, while that's very, very useful, it is not sufficient, and I'll show you why. In the area of pain, you say, okay, here we have an incredible opportunity. 100 million people that are suffering from pain, and yet we don't have many medications. And for many, many years, pharmaceuticals have actually poured millions of dollars in order to develop an opioid medication that would not be addictive. And this resulted in 0 results. And so what many of the pharmaceuticals have done is actually disenfranchise themselves from the development of pain medications. Now, science has now recently, with the ability to actually identify the three-dimensional structure of the mu-opioid receptors, been able to identify that the mu-opioid receptor actually signals intracellularly to various pathways. And 2 of them appear to be particularly relevant. The classical G protein one that is necessary for analgesia, but they also activate this pathway over there that's called beta-arrestin. So since the G protein is the one that's associated with analgesia and the beta-arrestin with side effects, what pharmaceuticals now are doing is developing medications that do not engage the beta-arrestin pathway, with the notion that these medications will be useful for pain management without producing overdoses or without producing addiction. And research is underway. Phase 2 clinical trials are being done in one of those compounds, Travedas 130. For overdoses, what is the issue? Completely, you say, the more widely available naloxone is, the greater the likelihood of success. But now with fentanyl and carfentanil, we're finding that actually the naloxone cannot revert these patients and they need much higher doses. And in many instances, it's almost impossible to actually resuscitate them because they die actually as they are injecting the drug. The drugs, the fentanyl, and these other analogs get into the brain so rapidly. And very importantly, these patients that are resuscitated then overdose again and eventually die. So we need to develop interventions that will link these individuals that overdose with treatments so that they do not that we can protect them for future overdoses. And finally, medications. We have the 3 medications, methadone, buprenorphine, and Vivitrol, each of them different characteristics. Methadone, full agonist; buprenorphine, partial agonist; Vivitrol, antagonist. And depending on what characteristics, you can use one medication or the other. Very useful. They prevent overdoses, they prevent relapses, they prevent infectious diseases, but they are not being used. And actually, less than 15% of individuals in the United States that could benefit from a medication are getting it. Multiple reasons why that is the case, including stigma, but also lack of infrastructure. So we've been working with the healthcare system in order to engage physicians on the proper treatment of opioid use disorders, to actually see it as part of their responsibilities as physicians. Developing medications, alternative medications that will improve compliance. This is a partnership that we did with a pharmaceutical that resulted in a medication that requires administration every 6 months, which of course would facilitate the compliance of the patients that are addicted to these opioid medications. And finally, with science, of course, we look at transformation. So an area that we have been exploring, not just for heroin, but also now for fentanyl, as well as cocaine and nicotine, is the development of vaccines. Vaccines just using the same strategy as we use for other vaccines that will generate antibodies against these drugs, so that when the person takes the drugs, the antibodies bind to it and interferes with its entrance into the brain. These interventions would be useful not just for preventing overdoses, but of course for treating those that are addicted and perhaps into the future for prevention. And with that, I want to actually just advertise some of the documents that we get if you're interested on any information regarding our research programs. And again, I want to thank you for your attention. Thanks very much.
Thank you, Dr. Valcao. This has not been a real cheerful session, but I note that a lot of you are interested. There's a very high attendance. I'm hoping our next speaker gives us a little cause to walk out of here with a little bit of hope. Our speaker is Karen Drexler. She is the National Mental Health Program Director for Addictive Disorders in the Veterans Administration. And who should know more about misuse of drugs than the Veterans Administration. Dr. Drexler is certified in both psychiatry and in addiction medicine, and she is going to talk to us about treatments.
Thank you so much. I am very honored to be here. Thank you to AAAS and the Dana Foundation for this invitation. And I'm delighted to give you a third perspective tonight. I am, as Deborah said, an addiction psychiatrist. I still practice at the Atlanta VA Medical Center, where I've practiced for most of the last 25 years. And I also, for the last 3 years, though, have been working for VA Central Office here in Washington, D.C., doing addiction treatment policy and having the opportunity to be a consumer of science on two levels, both as an individual practitioner, but also as someone trying to translate the science to improve the health care of a population. So I'm employed full-time by the Department of Veterans Affairs, and I have no commercial financial conflicts of interest. And tonight, what I'd like to do is talk about, I don't have to talk about opioid use disorder because Dr. Volkov has done such a terrific job of that. And I'll mention, as Dr. Ciccarone also spoke about, how opioid use disorder treatment really begins with prevention and how we've used the science to inform our policies about that. And then also how effective opioid use disorder treatment from, I think, a little bit more of the side of the art of medicine, how we apply what the science has shown us in a way that's patient-centered and collaborative when we're working at our best. So I'd like to share a case example. This was a patient of mine about 10 years ago. And I share her story. She is a veteran, but because this could be any one of us. She was a very hardworking, licensed professional nurse, practical nurse, who was referred for substance use disorder treatment after an overdose. And this is really the culmination of 30 years of experience with prescription opioids and other controlled substances. She injured her back at age 24, and she was treated briefly with some opioid pain medicine. She had a series of re-injuries and surgeries, and ultimately ended up being treated with both opioids and muscle relaxants, various benzodiazepines, and multiple providers. As her tolerance increased, as Dr. Volkov described, her drug hunger became greater, and even by shopping for multiple providers, it was not enough, and she ended up buying some pills on the street and ended up with an overdose. Now for her, I've shared here the DSM-5 criteria for prescription opioid use disorder. If a patient is taking opioids as prescribed, we don't include the increasing tolerance or the withdrawal symptoms as criteria for making a disorder diagnosis. But she really had most of these symptoms. She had craving or strong desire to use opioids. She was using in situations when it was hazardous, when she was really too intoxicated to drive. She was using larger amounts than she intended and had difficulty cutting down. She was spending a lot of her time figuring out how to get her next dose of opioids and continued to use despite knowing that opioids were causing major problems. In fact, after the overdose, her primary care provider said, "I will not prescribe opioids for you unless you go to the substance abuse treatment program." And that's why she saw me. I was the gatekeeper for her next prescription of opioids that she was hoping to obtain. So as both previous speakers have talked about, since the 1990s, opioid pain prescriptions have increased, but we really have not seen any change in Americans' reports of pain. However, the overdose deaths have increased dramatically, and as have the number of people who have developed opioid use disorder, those intertwining epidemics. And this was just my slide. Those of you who are epidemiologists in the audience may recognize this is a map of London in the 1800s showing cases of cholera that Dr. John Snow traced to the Broad Street water pump. And the solution was to take the handle off the pump, and had a tremendous effect on the cholera epidemic. I think this slide that we've already seen some versions of this, where as the kilograms of opioids sold went up, so did the deaths due to opioid overdose and the admissions for opioid use disorder. This is our map of London for the opioid epidemic. And one important intervention, as has already been discussed, is to take the handle off the pump and to reduce the number of prescriptions for opioid pain medicines. So the Centers for Disease Control and Prevention has developed an evidence-based guideline in which they recognize that non-opioid therapy is preferred for chronic pain for the reasons Dr. Volkov mentioned. When using opioids, to use the lowest effective dose for the shortest period of time, and to exercise caution and monitor closely. In the Department of Veterans Affairs, we partner with the Department of Defense to create our own clinical practice guidelines. We have them for many medical conditions. And we use, as the CDC did, the GRADE methodology, which takes into account 4 domains, including the balance of desirable and undesirable outcomes, and our confidence in the quality of the evidence, as well as other factors. We use this evidence hierarchy that may be familiar to many of you in the audience. Whereas earlier guidelines were often based on expert opinion, for these guidelines we looked to at least observational studies that show some control element, and the best of all, randomized controlled clinical trials, or even better, meta-analyses of multiple clinical trials. And based on these, we came up with 18 evidence-based recommendations to our practitioners, but I'm highlighting 4 of them here. We recommend alternatives to opioid therapy, such as self-management strategies, exercise, Tai Chi, other non-pharmacologic treatments, and when pharmacologic treatments are used, non-opioids over opioids, things like non-steroidal anti-inflammatory drugs, ibuprofen, and the like. We recommend against, strongly, initiating long-term opioid therapy for chronic pain. And we recommend for patients who are receiving long-term opioid therapy, ongoing risk mitigation, things like monitoring urine drug testing, checking state prescription drug monitoring programs to make sure we're not double prescribing, and monitoring for overdose potential and suicidality, and providing overdose education to our patients, prescribing naloxone, making it as widely available as possible, and intervening, assessing for suicide risk and intervening when necessary. And finally, as did the CDC, we recommend monitoring patients who have chronic pain for the development of opioid use disorder, and when we find it, providing medication-assisted treatment. So in the VA, in order to take the handle off the pump, we have been reducing opioid prescribing through our opioid safety initiative. And this has been an education for providers, as well as some metrics for quality improvement that we have disseminated throughout our system. We have some key metrics, and we have seen some improvements in opioid prescribing, a 33% reduction since 2012 in opioids over time. And these are numbers of veterans receiving opioids. The numbers of veterans receiving long-term opioid therapy has been reduced by 39%. And the veterans on long-term opioid therapy with a urine drug screen in the last year has increased to 87%. We are communicating with prescription drug monitoring programs in all but 5 of the states, which is a tremendous technical feat because not every state prescription drug monitoring program uses the same software, and they don't necessarily communicate with each other or with us. But I have to give credit to my colleagues in pharmacy benefits management and in IT for overcoming many hurdles to get to this point. We've already seen these slides before, so I won't go into much detail, but the VA is not alone. Nationally, we've been making progress, and yet overdose deaths have continued, and this is a complicated picture that Dr. Ciccarone helped to discern for us of intertwined epidemics. But as Dr. Volkov also pointed out, patients who are prescribed opioids long-term are at greatly increased risk for developing heroin addiction. So let's get back to my patient, the nurse. When her physician told her no more prescriptions, she turned to the illicit market. And when she came to me for treatment, I talked with her about buprenorphine naloxone. Now, I explained to her the mechanism of action and took this approach, which we're advocating system-wide, that patient treatment for opioid use disorder, just like for pain, should be patient-centered, it should be evidence-based, it should be life-sustaining, and empowering the patient to be a partner in their care, not a passive recipient of care. And it also needs to be accessible to those who need it. So for patient-centered care, it begins with shared decision-making. The patient is the expert on his or her life. Hopefully, we clinicians are experts on the entire menu of treatment options, and we provide that information in a way that's easy to understand. And my colleagues in the VA in our academic detailing service have created some education materials that make it easy to convey the rationale for medication-assisted treatment. Opioid agonist therapy is a particular kind that includes both buprenorphine naloxone and methadone. And it has been shown through science to reduce HIV risky behavior, criminal behavior, cravings and withdrawal, and importantly, opioid use. And as Dr. Volkoff also showed, there are two kinds. Methadone is a full agonist, and then buprenorphine is a partial agonist, which has a unique mechanism of action that makes it safer to prescribe in any setting. Methadone, because of its full mu agonist properties, is really only available through special SAMHSA-certified opioid treatment programs. And then there's the full antagonist naltrexone. So I'm able to provide this information. Buprenorphine is more widely available. You don't have to go to a special clinic every day to pick up your medicine and take it in the clinic. It is FDA approved, it improves treatment retention, it reduces mortality, and it's recommended for most patients except those who have an anticipated need for opioid pain medicine. So I talked with my patient about how some patients find that actually getting on buprenorphine helps improve their pain. We also discussed one other option, which was the extended release injectable naltrexone, which would block the mu opioid receptors and any opioids for pain. And she elected not to take that one. So I wanted to also mention that it's not just the medication alone, but also medical management. This is what we've called it in our clinical practice guidelines. There are several research studies showing this approach, that relatively brief counseling but close monitoring by the clinician, including drug testing, asking the patient about their use, asking about consequences, and potentially using a measurement-based tool like the Brief Addiction Monitor, educating the patient about the opioid use disorder consequences and treatments, connecting the dots, if you will, and encouraging them to abstain, to attend mutual help groups in the community, and to make important lifestyle changes. Now, my particular patient was also attending a lot of groups and classes, so she was learning at a rapid pace different skills to support her. And she elected to take buprenorphine naloxone. Because of her pain, or chronic pain, I suggested that she split the dose and take it twice a day rather than once a day. And she completed our intensive outpatient program. But really within a week of starting this medication, she was so engaged and learning so much. She started exercise, she started being active in 12-step recovery groups, and then I transferred her to a continuing care group because of our system. I work in the intensive phase, so she had graduated and moved on to a less intensive phase, but she kept coming back at every opportunity, stopping by my office and saying, "Dr. Drexler, that was the best medication, I can't tell you," and telling me about another person that she knew back when that she saw and encouraged to come and find treatment. It really turned her life around. And she remained in recovery on medication for years. As I said, she moved on, and she keeps dropping me in every once in a while to let me know how she's doing. So I wanted to raise this issue that Dr. Volkoff also raised, that we our treatment for substance use disorders is often episodic, as if we were treating a case of pneumonia. And once we finished a 28-day inpatient intensive program, we would be cured for the rest of our lives. But these are really more chronic illnesses that would benefit most from the long view, from a chronic disease management model. So this is something that is, we're taking the synthesis of the evidence and suggesting this model moving forward. And this is really a work in progress. We haven't implemented it yet, but we're promoting self-management. We have good evidence that participating in group mutual help like Narcotics Anonymous or Alcoholics Anonymous is helpful. Teaching coping skills that folks can use to cope with pain or to help to get to sleep without using medications. And then disseminating out the evidence-based treatment into general healthcare settings wherever the patients are presenting, in primary care, in pain medicine, in hepatitis clinics. And then also keeping infrastructure in SUD specialty care for managing those most complex patients. Now this slide, I apologize because I know you probably can't see the graph, but what I'd like to point out on the graph is that the medication-assisted treatment with buprenorphine and with methadone both reduce mortality for those with opioid use disorder, and it's not just overdose mortality, it's all-cause mortality. So, what are our challenges and next steps of getting this life-saving treatment to those who need it? Among, Dr. Volkov alluded to this earlier, among privately insured patients hospitalized for opioid use disorder, only 17% received medication following their hospitalization. Can you imagine if we treated diabetes the same way? 54% received some psychosocial services following hospitalization, but 40% received no continuing care. According to SAMHSA's treatment episode dataset in 2013, 27% of treatment plans for heroin use disorder in SUD specialty clinics included medication-assisted treatment. We have a long way to go. And in the VA, patients who are clinically diagnosed with opioid use disorder, that's throughout our system, wherever they present, 34% received medication in fiscal year 2016. So we can anticipate that demand for opioid use disorder treatment is going to continue to increase, and our next steps are challenges on how to disseminate these evidence-based practices widely so they're available. So as I mentioned, the good news is we have, even as demand has been increasing, some of the efforts we've made to educate providers and to support them with consultation and education have increased our prescribing. And then I'd like to just present to you 4 evidence-based models that we might follow. One is brief counseling is sufficient for many patients with opioid use disorder. This is David Filene and colleagues' work in which they randomize patients in primary care to receive physician management, this brief counseling that I mentioned before, either once a week, tapering to monthly for stable patients, or receive that with an additional hour of counseling. All of the patients received buprenorphine naloxone. They had some pretty amazing results. Almost 80% retention in treatment at 12 weeks, and 4 to 5 weeks of continuous consecutive abstinence. But that additional hour of cognitive behavioral therapy, which we know is helpful, really didn't make a difference as long as the medication was prescribed with close monitoring and that brief counseling by the prescriber. So I think that's an opportunity to disseminate this more widely. This is from the NIDA Clinical Trials Network, Roger Weiss and colleagues, that similarly disseminated out a very similar model based on Dr. Filene's model to general mental health care settings. And what they found was that while patients were engaged in treatment on the buprenorphine, their chances of remaining sober were 10 times greater than after the buprenorphine was tapered off at the end of the trial. And this is the so-called Massachusetts model of nurse care management. by Dan Alford, Colleen LaBelle, Jeff Samet, and other colleagues, in which they've taken the Filene model and instead of the physician or the prescriber doing the brief counseling, trained nurse care managers to do the brief counseling and the close follow-up. And they work within a team with a clinical pharmacist and counselor as well. And they have been able, through that model, to dramatically increase the number of patients receiving buprenorphine. And then another similar but different model in the state of New Mexico, as you saw, that was heavy hit early on in the opioid crisis. The state of New Mexico realized they needed to disseminate medication-assisted treatment out to rural areas quickly, and they developed a model using a telehealth hub in which providers in primary care clinics in rural New Mexico had a weekly meeting, basically clinical rounds like you might have done in medical school and residency, only done virtually using telehealth. And with that consultation and training, they were able to dramatically increase the availability of medication-assisted treatment. And then finally, I'll mention this one model that's from the alcohol literature. This is Dave Oslin and colleagues in the VA who randomized patients to receive alcohol care management, again with care managers supporting the primary care docs, as the primary care docs prescribe naltrexone for treatment of alcohol use disorder. And they found that those who were randomized to receive that care in primary care, not only were they better engaged in treatment because they didn't have to pass from one clinic to another, but their percent of heavy drinking days also was superior to those who got treatment as usual. So I'm very hopeful that we'll be able to disseminate these models out. And one key partner, at least for us in the VA, is academic detailing, in which we use the same techniques that pharmaceutical companies use to promote new products to promote evidence-based best practices. And they helped partner with our overdose education and naloxone distribution. And this is just a graph that since 2014, when we started this, we have actually dispensed over 71,000. At this point, it's over 75,000 naloxone rescue kits. So potential next steps, I think there's a lot more to be done in terms of implementation science. We have some actual treatments that work pretty well, that are well established by the science, but getting them out to the patients who need them is the next challenge. There are also new, exciting, even better medications on the horizon that Dr. Volokov talked with us about. And how we can enhance education. Right now, in order to be able to prescribe buprenorphine, physicians have to take an 8-hour training course. And nurse practitioners and PAs, physician assistants, have to take 24 hours of training. That seems like a burden for someone with a busy clinical practice. But why is anyone graduating from medical school or nurse practitioner or PA school without having that 8 or 24 hours of training in their basic curriculum? So that's one area where we could improve. And we could also let folks in the field try some of these models for implementing, like Nurse Care Manager, like the ECHO telehealth hub and spoke, and learn from those and apply the lessons learned to continuously improve our processes. So opioid use disorder is preventable, it is treatable. Effective treatment is patient-centered and evidence-based, and we do need more help for newer, better treatments, as well as how to implement the ones we have. Thank you.
Dan and Nora, would you come up? We're going to take questions from the audience, but you need to line up. There are microphones in the 2 aisles, and when I call on you, please give your name and affiliation or status. I wanted to ask a question of, well, let me start with Karen. Karen, is there a difference between the veteran population and the non-veteran population, men and women of the same age group in terms of their rate of taking drugs or using opioids? Let's
So-
stick with opioids.
Okay, so there is an increased risk for chronic pain among veterans. And I don't know off the top of my head about
Okay.
whether we prescribe opioids more for patients who have chronic pain than
Yeah.
the general population.
It does make sense that veterans have more chronic pain. They've had very physically
Demanding
rigorous,
jobs. They jump
very
out of
demanding.
perfectly good airplanes.
Yes, my son did that. Dr. Volko, why is it that some people can have, for example, break a bone or have surgery and be prescribed an opioid and take it for a period of time, and some people become addicted and other people just quit taking it?
Well, we are all built differently, and one of the things that we've come to recognize, not just for opioids, but for any drug, is that there are some people that are more vulnerable to become addicted than others. So what, of course, physicians always want to know is, can you give me a test that can let me know if I'm going to prescribe them an opioid, are they going to be at higher risk or not? We know that a lot of that vulnerability is genetic, but we don't have the genetic test right now that can help us. But there are many things that we can actually ask patients that can give us an idea of the risk. One of them, have they been addicted in the past to drugs? So if they had a prior history of addiction, whether it was tobacco, alcohol, or certainly opioids, should alert physicians that that individual is at high risk. Also, age. We know that the younger you are, the greater the risk that you may have of becoming addicted. This is one of the reasons why, in general, opioid medication should not be prescribed to teenagers unless they are necessary. And so, family history also is a factor that contributes to that. Mental illnesses can increase your risk for becoming addicted to drugs because they actually, in many instances, can make you feel better, and that leads you to actually seek them out in order to auto-medicate themselves. But at the end of the day, there is not a test that can guarantee you that a patient is not going to become addicted. There's these factors that tell you if someone is at greater risk. So if someone is going to be prescribing opioids repeatedly, just as it's described in the CDC guidelines, these require that they be monitored very, very carefully, that every time that a prescription is going to be renewed, that the physician evaluate to ensure that there's not any development of misuse of opioids or addiction.
Thank you. Dan,
Yes.
I wanted to refer to your graph that showed the heroin users on the left side, the younger users. Are they just switching over? Are they just people who are switching from, they would have been cocaine addicts or something else years ago, but now heroin is the in drug, or it's less expensive or something like that? Or are these attracting some new people who never would have become addicted to another substance?
Well, just like the previous question, we'll say that, the answer is complex and
Yes.
it's not completely known at this point. We are in this wave effect, and epidemics can have this sort of wave effect that just sweeps in people and increases the size of the vulnerable population. Like, we tested the size of the vulnerable population by excessively prescribing opioid pills. But what I would like to answer your question with is with an anecdote. An anecdote. And that is, in my observations, my team and I have been to mill towns outside of Boston, Lawrence, Lowell. We've been to Baltimore, Chicago. We've been to West Virginia. We see a lot of new people out there. And the new people aren't necessarily coming from prescription pills anymore. There's a new wave that are coming in. They're young. And I'm not sure whether they would have done another drug if heroin wasn't the thing now. But I do know that there's a mixed picture right now. There's also a cultural wave. Another anecdote, for example, I met a 29-year-old in a small town outside of Charleston, West Virginia. Nice guy, works. Just also happens to have a daily heroin habit. And he went back to his 10-year high school reunion. Small town, everyone knows everyone's business. Everyone knows who's left, who stayed, who's lived, who's died. Half half his high school class is gone. The first time in 17 years, I almost had to stop an interview because I had a very emotional response to that. Pills and alcohol, pills and heroin. There's some one or two motor vehicle or industrial accidents, but mostly pills and heroin. So there's something very large out there happening right now. There's not going to be any easy answer to.
Yeah. Well, okay, let's take some questions. Go ahead.
Thank you. My name is Ashby Sharp. I'm the Chief of Ethics Policy at the Veterans Health Administration, and I just wanted to add a dimension to Dr. Drexler's excellent presentation that one of the things that we did in our policy on long-term opioid use was to prohibit the use of pain agreements or pain contracts, because from an ethics perspective, we felt that they were unenforceable and adversarial, and instead we substituted a robust informed consent process so that patients get education and a good conversation about the risks, benefits, and alternatives to long-term opioid use. But the two questions I have are actually about integrating policy strategies. So patient satisfaction surveys. I've heard from clinical providers outside of VA that they feel pressured to prescribe all drugs, but in particular analgesics and opioids, in order to, for patients to give them a positive satisfaction rating because they're going to be judged on that. And the second was, what about third-party insurance coverage for opioid use treatment, and what can be done to encourage other players in the market to get onto this initiative?
Dr. Drexler, do you want to take that?
I'll take the first one.
Take the-
I'm not an expert in third-party payers.
No, I don't think any of you are, probably.
Okay, having been in the VA. But I am on the steep end of the learning curve about unintended consequences of policies. And my thought about it is it's a little like safety and efficacy trials in medication development. You do phase 1, safety in healthy individuals, phase 2, safety in individuals that are affected, phase 3, the randomized controlled clinical trials, and if they are positive and encouraging, then you roll it out and you monitor to see what happens out in the real world. And I read a paper just this past week that about a third of the adverse events that we know about, we learn about after market, after the FDA has approved. And I think the same thing happens with policy. We do our best, as you saw, to create policy based on the science of what seems like it'll work. But when you roll it out in the real world, you don't know exactly what's going to happen. And so I think it's very important that we keep monitoring in the same way we try to monitor when we roll out a new drug to see if our new policies are having the intended effect or if there's something we couldn't anticipate, and then make course corrections as we need to.
You know, and I'm just going to comment on that second question because it's not that I'm an expert on insurance, but I write a lot about the issue of opioid medications and their use for chronic pain management. And I get emails from physicians that are experts on pain and says, we completely agree with you with the recommendations of not using opioids as the first line of treatment, which is what the CDC guidelines are saying. The issue that says the problem that we have is that not all of the insurances actually cover for it, and in the paperwork that's required in order to justify some of these alternative treatments, which are considered first line of treatment for some of these pain conditions, are not accepted by the insurances. So as a result of that, physicians cannot do the right thing because it's much cheaper to prescribe an opioid medication. So one of the things that is clear is, yes, we need to educate physicians on proper management of pain and proper use of prescription medications, but we need to do structural changes into our healthcare system such that the proper treatments are covered by the insurance. Because otherwise you can write all of the guidelines that you want. If someone is not going to reimburse the patient, they're not going to be given that intervention. And so that is an aspect that we need to also be very aware of, that we generated a system that has favored now the way of treating that is far from optimal, that actually facilitates prescription of opioid over other interventions.
Thank you. Yes.
Ken Dillon, CNC Press. In the past, the government of China does not appear to have been very tough in cracking down on suppliers of synthetic opioids. But I'm wondering if there's any evidence now that opioid addiction of this sort is spreading in China itself, and might that lead the government to become more serious?
Oh, I don't have any evidence for that. I know that stimulants are very popular, used and abused in Southeast Asia, but not necessarily synthetic opioids. There is high-level agreement to restrict a number of fentanyl and a number of its cousins from being produced and exported from China. I would have to say, though, my own personal opinion is fairly cynical on that. I'm not sure how one effectively controls the tiniest fraction of an illicit production in a country with enormous industrial capacity. I'm just not sure how, even with laws and regulations prohibiting the production, how they're actually going to pull it off. But it's China. Maybe they will. I mean, I want supply control to happen. I really do. But it hasn't worked very effectively for drugs like cocaine and heroin in countries that have a lot less pull in the world than China does now.
You know, I was in China last year, and we were trying to actually create new models for treatment of patients that have heroin. And they have, of course, a very severe problem with heroin abuse, but they've been actually quite successful on implementing methadone clinics. But I was specifically interested, exactly like you, on that question. Are they seeing the consequences of these synthetic opioids? So I met with the director of the CDC, and I asked him, have you started to see an increase in the number of overdoses that may be pointing out to the fact that you are lacing heroin with fentanyl? And he did not know about it. So I mean, but again, I think that the issue is a very different country, and they have abilities of implementing interventions in ways that are much faster than us. But on the other one, I do not know the extent to which there is an accurate knowledge of the magnitude of the problem. I don't know how good their survey system is. So I was surprised about it, but they didn't know.
From this side?
Hi, Ed Bilski. I'm at Pacific Northwest University. And as a basic scientist, I get the value of the research, both fundamental and clinical. As a medical educator, we're doing our part at the university to better educate through an interprofessional approach. But it's disheartening to see statistics like the private insurers, only I think it was 17% that are privately insured are getting the treatments that we know to have at least some effectiveness. And then you start to look at more rural populations, at-risk populations, underserved medical communities, and those numbers are probably even more strikingly against us. Take that a step further, and thinking about the demand for these opioids and the opioids connections with social bonding, for example. What's going on in our society, and how and who will address some of these more fundamental things that drive people to take a variety of different substances or do certain behaviors in excess that harm them and also the community? Who's going to take responsibility for that?
Dan, do you want to take responsibility for
Yeah,
this?
I'll start. So there's sort of two halves to your comments. So the first part is I think we either have or will have a severe labor shortage in substance use treatment. There's simply not enough providers, and the providers are not distributed in a way that meet the problem. I just have sort of West Virginia in my head right now. So promoting medical education from medical school through residency could help. We could also help. What help would be incentive programs, whether it's loan repayment or other kinds of incentives that would promote a generation moving into psychiatry, mental health, addiction medicine. I think would be tremendously helpful. As far as the second question goes, I'm actually writing a paper with a couple of colleagues right now looking at what are the deeper root issues of this, because I agree with the line that we're saying that excessive prescribing caused the wave effect that we're in, and that we need to turn that tap off. I love the example of the Jon Snow example. We need to take the handle off the water pump. But there's a reason why this epidemic settled in the areas that it has settled into, right? There's a miasma going on, multiple overlapping comorbidities that say something about this segment of American society. And whether it's poverty, disenfranchisement, lack of future, lack of opportunity, lack of hope, there's some what they call diseases of despair that are lining up in Appalachia up through the Midwest and over Eastwood. That is a much more complex set of problems that we need to address. But thanks for bringing that up. That just makes it a little. I'm feeling a little sense of despair and hopelessness too. But I do go back to that HIV slide, and that is that we did turn that epidemic around. So this specific epidemic, we have the evidence base, we have the tools, we have the ideas. We need some resources, and we need a creative way to take those resources and apply them into the regions, telemedicine and that kind of thing, to get them to the areas that are having, that might be culturally shifting to want to use opiate substitution therapy or this, this medically assisted treatment, but may not have the experience or the personnel to do it. We can use, creative approaches, telemedicine and the like, to get that. So the specific epidemic, I think we can address and turn around. The larger fault zone problem, I'm not quite so sure about.
And I would like to reiterate that because I think that in many ways, I think that we need to end up in a very positive way. I actually look at it from the perspective of saying, okay, what is the challenge that we have on addressing the opioid epidemic? We know how to do it. We have a roadmap that if we implement, we will succeed. And I always put the counter argument in. I said, if someone were to tell me exactly how would you address the problem of the Alzheimer's, I wouldn't even know how to start. We don't have treatments. We don't know how to properly prevent it. Here we have a much better understanding. We know where the epidemic generated. We know how it grows. We know how to prevent it. We know how to treat it. But it does require a very integrated approach of resources to do it. We've done very successful campaigns on preventions of other drug use disorders. Look at tobacco, how we have dramatically reduced it. So we can do it. I mean, obviously, it's going to require an investment. And one of the things that is important, because we haven't been discussing it, is we have the 21st Century Cures Act that's putting $1 billion for the treatment of opioid use disorders, which is fantastic. We've never seen anything like that. But the problem is we want to be sure that that funding goes for evidence-based treatments, for quality care, which is not something that we really speak very much about it in terms of substance use disorders. We speak about quality care on cancer, but not here. And we need to demand that. Actually, we need to demand and use this as a way of improving the quality of care for people suffering from opioid use disorders or any other addiction.
Thank you. I'm going to take this one and then that, and then we will adjourn and go and enjoy our reception.
Hi, thanks. Ashok from Sivakumar from Johns Hopkins University, also a veteran, U.S. Army. Thanks for your time today. Two hopefully short questions. One actually builds upon what you've been talking a little bit about, but I wanted to ask you specifically from the VA, whether it's mining industries or other industries, auto industries, or any industries that seem to have slightly have been degenerated in the past century, in the past few years for new jobs. I think veterans also face a transition crisis when they come out. And I was just wondering, what are some programs now? I luckily have a civilian healthcare system that I can depend upon, but I do get messages as well from the VA, but it seems to me that there's a lack of communication overall with the overall transition as veterans go in and out of different healthcare systems to really understand what are some of these risks. So I was wondering if you could touch upon that. Second part of the question, more specifically for the other members of the panel. You mentioned a lot of time today about heroin, but from the SAMHSA statistics of 2016, which are discussing the past year initiates of specific illicit drugs among persons aged 12 or older, let's say, for 2015. Marijuana is at 2.6 million. Pain relievers in general are at 2.1 million. Cocaine is at 968,000. MDMA is at 839,000. LSD is at 664,000. And methamphetamines are at 225,000. Whereas heroin's pretty low at 135,000. I'm just wondering how you mentioned slightly, you touched upon it in your last slide, sir, about separating out the heroin problem from overall pain relievers. From these statistics, it appears that heroin is quite low on the scale, and that maybe conflating these operations, maybe just doing us a disservice. I'd love for you as well to touch upon that. Thank you.
Okay, may I take the first question first?
Yeah, and we are going to have to be brief in our answers and
Succinct.
brief in our questions.
Okay, so I'll be as succinct as possible. I'd like to thank you for your service and just ask you to please Google Department of VA. We are a huge organization, and we do have a transition care program, care management, so that veterans who are leaving the DoD can engage in healthcare with us. We also have programs for education and for employment, and so please reach out to us and let us help you.
Great. In the second half,
To clarify, it wasn't specifically my case. I think I'm asking more for what I'm confident of. More than 80% of guys coming back are not going to Google that. If you can touch upon how you're going to reach out to them.
Okay.
Dr. Volkow will probably want to weigh in on this as well, but thanks for bringing up the fact that there's, this is one piece of a much larger issue about American society. There are other drugs of misuse and abuse, some of which are very common. Marijuana is very common. Marijuana is not deadly. Heroin just happens to be deadlier than the more common drugs. And we should always remind ourselves that, that one of the legal drugs that is deadliest is alcohol. And so we have to constantly remind ourselves that working with teens and vulnerable populations to reduce progression from what might be light level of alcohol use, recreational use, or normal social use, to not progress. Because people there are testing their genetics. Alcohol is a highly genetic predisposition, and people should know their family histories and magnified resilience factors to not progress. I just happen to know heroin well, and that's why I'm here tonight. I'm going to emphasize heroin. We are on a death wave with heroin, and we need to address it, or there'll be segments of the country where we're going to lose a piece of a generation.
Can we go over here now?
I'll try to keep this very brief, but thinking about what you just said about losing segments of generations and the comment previously about diseases of despair, I was wondering if there's any research on the overlap between overdoses that may also be suicides, and thinking of suicide as a major public health crisis right now. Do we know anything? What kind of research is being done? How do we separate deaths that can be treated by substance use treatment, but also those that may require more specific suicide prevention intervention?
Very important question. And indeed, we don't know exactly what those numbers are. So from those 33,000 deaths on opioids, it's possible, and I think that I wouldn't be completely off the mark, that 15% of them are related to suicides. And we know that the loss in years in terms of your lifespan expectancy in the United States that we're seeing in middle-aged white people is related not just to the overdose, but also to the significant increases that we're seeing in suicide. So we also know that in individuals that suffer from depression, if they are actually taking opioids, their risk for suicide is much higher. So there is a very strong comorbidity between both of them. And indeed, one of the things that the CDC guidance tell you among the factors that are associated with higher risk of overdose is having a history of depression. Because if you are depressed and they prescribe you an opioid, your risk for suicide, particularly if you're a woman, are like 8 or 10-fold higher. It's a huge effect. So yes, indeed, and in many of these overdoses, of course, we're seeing intentional overdoses, and there's really no way that we can distinguish one from the other.
Well, this has not been the most cheerful of events that we've held with the Dana Foundation, but I actually do think it is one of the most topical and important, and the large size of the audience, I think, attests to that. So before we go off to the reception, I would like to take one more chance to thank the Dana Foundation for all they've done. And also to thank our terrific speakers.